Thank you, sir. And this talk will be what we routinely do, not only for cluster, regularly what we have to do to prevent any kind of infections after cataract. And this, already Dr. Dear sir, as well as Saravanan already mentioned what is the difference between sporadic endophthalmitis and cluster. But in case of cluster, as already mentioned, usually the source of infection in any endophthalmitis can be from the patient or from the hospital or from the healthcare personnel. And in case of cluster, we can rule out the first incident from the patient. So the next two, the hospital as well as the healthcare provider, we have to concentrate on that. So when as a prevention, all the source can be anything, whatever supply we use, consumable we use during the surgery, starting from, as mentioned, even a topical anesthetic drop. From there, anything it can be, even our tap water, as in the case of acanthamoeba that was suspected to be the culprit. So anything can be the source. So we have to, normally we have to keep an eye on all these things, and you have to maintain a very strict and standardized protocol in using all these things. Let us start with from the patient. Concentrate on the patient's periocular area, especially if the lid margins, because MGD is a very common association in elderly people who come with cataract. And especially nowadays, when we plan for a same day surgery and all, it's better to concentrate on this area and look at, and if it is significant, better to postpone the surgery, prepare the ocular surface and lid margin with the regular therapy like systemic doxy or azithromycin, hot fermentation, or even nowadays recent gadgets are there to go for instant massage and removal of the material inside. And this we have to do, and then take up the patient for surgery. In case of sometimes we come across something like pustule, they used to call, but usually they are some cyst or chalazion, a burst chalazion with a granuloma inside. They are not infective conditions as such. Either we can just ignore them and go ahead with the surgery, or to be on the safer side, we can go and meddle them, like we can scrape them off or open them up. But if we do something like that, always wait for 3 days, treat them with antibiotic, and then take them up for surgery. Don't do it at the same sitting. And it's very important to do either Roplas or syringing. Syringing is not that much routinely done nowadays, but the just pressure on the lacrimal sac area and looking for any regurgitation is a very, very important, simple test which has to be done by the doctors. And treating any ocular surface problem like allergy, dry eyes, and especially patients who are on topical medications for a long time, like in glaucoma and all, we have to pay attention to the ocular surface, and we have to treat them and control the condition, and then go for surgery. And also we have to address the lid problems also. And in case of culture, conjunctival culture should we have to do preoperatively as a routine. As a routine nowadays, it's not being done. But as I said, patients on some topical medication for a longer time, or who are having some periocular or ocular surface problem, it's better to do. Or also in one-eyed or uncontrolled diabetics and all these patients, better to do a conjunctival culture, at least to be on the like a protection for you later if there is any untoward incident occurs, and then go for surgical intervention. And also it's important to attend their systemic problems. A good glycemic control is very, very important. It's not that on the day of surgery, the blood sugar level is whether it is controlled or not, because that alone is not enough. We have to go for HbA1c, and also advise the patient throughout the healing time also, their sugar level should be controlled. And in case of patients with COPD and other allergies or asthma, whether they are on some steroids or any immune modulators, then we have to consult with their treating person, whether they can be withhold or whether they can be altered, that we have to see. And in case of atopy, we have to be very careful. Atopic dermatitis, these patients are often prone for fungal infections. So it's better to get a dermatology clearance just before taking them up for surgery. And patients with emaciated look, always be careful, especially when they come in camp, because these patients are more likely to go for nocardial infections. We don't know from where it is coming. Is it from the lungs? We don't know. Is it endogenous? We don't know, but they are very prone for nocardial infection. And any other source of nidus or of infection like dental problem and other things also we have to look for in the patient. And the coming to if the person is an individual surgeon, of course, it's very important to meticulously attend their regular protocol, sterilization protocol, as well as the documentation of all the sterilization consumables we use. Dr. Adyar already pointed out, and Dr. Shivakumar will be talking about it in detail. And it's also important to maintain a log like this, which table, which surgeon, how many case it is, all these things. And if you are using EMR, of course, the timeout call will help in this. So meticulous documentation of all the steps in surgery is very, very, very important to find out the root cause later. And the preoperative eye preparation, topical antibiotics, whether they have to be used or not is still a question. And many people, even ACRS survey, they mostly 80% of them, they would like to use it, because to be on the safer side, the people like to use, but it should be started at least 3 days before. That's what they are telling. But one thing we have to keep in mind, it may reduce the colonies, but it will not alter the normal flora altogether. And also whether to use unnecessarily to prevent any resistant strain development, that also we have to keep in mind. So the most recommended one is the iodine preparation, 10% for skin and 5% for the conjunctival cul-de-sac, which has to be the contact period is more important than the concentration. At least for 3 minutes, it should be in contact with the conjunctival sac. So it's better in our camps and all, when we do large number, we prepare the patient when they are waiting outside once, and again on the table, and then apply, so that the contact time will be maintained toward the time. And there is some reports, especially from Japan, we can use it as a surface irrigation, so that it will reduce the positivity of the ocular surface pathogen is there, but it's a highly irritant drug also. We have to think about the surface toxicity, especially corneal toxicity also. So intraoperatively, as mentioned already, the instruments has to be properly laid out. The used instrument and the unused instruments have to be separately kept, and the tips should not be touched. And the preparation of the eyelash clipping is nowadays not being used, but we have to use a proper draping has to be done, which is covering the lashes very well. And it's better to go for disposable drapes rather than cloth drapes which are being reused. Then the section, is it the wound, whether a particular type of wound is more prone for infection? It is not very clear. Generally, clear corneal incisions are more documented to be more prone for infection because they are more exposed. Not only exposed, the reason we will see soon in the next few slides. But whether it is a superior one or a temporal one, it has both has advantage as well as disadvantage. More than the location, whether we have achieved a tight wound, a leak-proof wound is very, very important. So especially a clear corneal wound, if it is not really even a tight wound, sometimes has been shown to there will be ingress of fluid from the cul-de-sac, especially if there is the blinking movement and the negative pressure is being created. And that's why it's very important to make sure that there is no leak at all, or if you are in even a slightest doubt, better to go for suturing. And it is proven that a sutured wound, you can reduce the chance for infection greatly than in an unsutured wound. And so it's always, we have to hydrate nominally only. Should not be too much hydration, should not be done. And if you are in doubt, go ahead with suturing, don't hesitate for that. And then during the surgery, if there is a complication, especially the lens diaphragm is violated, the posterior capsule is violated, anterior vitreous face is violated, then the chance for infection is almost 8 to 10-fold. So it's better to, in these cases, approach differently. Better to add an oral antibiotic or systemic antibiotic on the safer side. How much it will help, we don't know, but still it's better to add, and also topical more frequent application, and closely follow them up, admit them and closely follow them up. That's very, very important. And in case of IOL, an injectable IOL is always preferred, because rather than an inserting IOL, which will, so that it will not touch anywhere on the ocular surface. And the intracameral antibiotic, the ACR, after the ACRS recommendation, This has become a norm nowadays. Initially, they recommend cefuroxime, but the problem mixing at that the compounding is a very important thing, because any dilution error can lead on to severe problems like foveal necrosis and all. It has been reported. And also cefuroxime being a penicillin group, like it can lead down to anaphylactic shock also. So moxifloxacin found to be a more safer drug. And also if it is available in a single use syringe, single dose, already pre-filled syringe, it is more ideal, and it can be given at the end of surgery, and then the wound can be sealed. And the external sealing, we can, this is my favorite technique. I used to paint it with a viscoelastic later, and also at the end also I used to put a drop of diluted 1% iodine. So the sealing wound is very important, and also PA at the end. And eye patching, better to go for eye patching at least for 4 hours. It has to be kept. And post-operative antibiotic, we have to be very careful, because in an uneventful surgery without any problem, optimally it should be used. It should not be used for a longer time to prevent any antibiotic resistance also. And post-operatively, nowadays patients are more would like to go back to their routine as soon as possible. Of course, we have to consider that, but at the same time, make sure that they understand that this is a surgery, and also there should be a balance in their activities post-operatively till the wound heals. At least, as you know, the corneal wound, a clear corneal wound, will take anywhere between 8 to 12 weeks to heal properly. That we have to keep in mind. So in conclusion, approach the patient as a whole, not only the eye, as a whole, systemic problems also. Many more attention to the periocular area. Monitor, and it's a routine. If in our institute, each surgeon, before starting the surgery, go and look at that logbook, whether the sister has entered everything. And then though the CSST team will do it routinely, we have to see and countersign. So make sure that you are sticking on to the protocol as well as the proper documentation, and then proper patient preparation. And the intracameral antibiotic also found to be really useful, and Dr. Haripriya can give first-hand information about it. Enhance the antibiotic prophylaxis whenever there is a complicated surgery. Thank you.
Thank you so much, madam, for an elaborate